Ruptured ectopic pregnancy is not an uncommon diagnosis in gynecological emergency admissions, but spontaneous tubal abortion with an intact live fetus is a rare event which can be diagnosed preoperatively with ultrasound. The aim of this study is to report a case of spontaneous live tubal abortion following ectopic gestation that was diagnosed ultrasonographically and confirmed intraoperatively. Keywords: diagnosis, ectopic, tubal abortion, ultrasound. Fembryal ectopic pregnancy resulting with a live fetus is a very rare entity. This case illustrates a case of 13 weeks viable fetus at the right fembryal end of the fallopian tube diagnosed with ultrasound and confirmed after surgery. Therefore, careful tracing the fallopian tube in its entire length is strongly suggested so that ectopic pregnancy cannot be missed, which can be fatal. Ruptured ectopic pregnancy is not an uncommon diagnosis in gynecological emergency admissions, but spontaneous tubal abortion with an intact live fetus is a rare event which can be diagnosed preoperatively with ultrasound. A high index of suspicion for an ectopic pregnancy is of great importance. The main problem of ectopic pregnancy is clinical presentation. Symptoms can vary from vaginal spotting to vasomotor shock with hemoperitoneuum. The classic triad of delayed menses, irregular vaginal bleeding, and abdominal pain are most commonly not encountered, but the exact frequency of clinical signs and symptoms is hard to assess. The case under review presented with lower abdominal pain with 12 weeks history of amenorrhea. Ultrasonography, but more precisely, transvaginal sonography, has become the gold standard diagnostic modality for the effective and fast detection of ectopic pregnancy. An important advantage of most currently used transvaginal transducers is the ability to perform simultaneous and spectral Doppler studies, allowing easy identification of the ectopic paratrophoblastic flow. However, due to non-availability of transvaginal probes in addition to religious and cultural beliefs in our environment, transabdominal ultrasound was used to diagnose this particular case that is here presented. Transabdominal ultrasonography, TAUS, cannot reliably diagnose ectopic pregnancy except when a live fetus is demonstrated in the abdominal cavity. In only 3 to 5% of the cases, an ectopic gestational sac with embryonic echoes and clear heart activity can be demonstrated. 12. In our patient, the TAUS was able to demonstrate an intact extrauterine viable fetus with active cardiac activity and well-developed fetal parts at 12 weeks gestations in the right adnexal region. Accurate ultrasound diagnosis of ectopic pregnancy depends strongly on radiologist experience. Adnexal abnormalities may be difficult to identify because of confusion with other adnexal structures such as bowel or other pelvic structures. There are other adnexal structures that may resemble an ectopic pregnancy and should be correctly identified. One is the corpus luteum, which is eccentrically located within the ovary, surrounded by ovarian tissue and possibly creating the impression of a sac-like structure. Other mimickers that need to be correctly differentiated from an ectopic gestation are a thick-walled ovarian follicle, the small intestine, and tubal pathology conditions, such as hydrosalpinx containing fluid. All these possible differential diagnoses were excluded during the scanning of this case. Using the protocol of combination of clinical examination, serum beta-eta human chorionic gonadotropin assay, and transvaginal ultrasound examination, it is possible to diagnose ectopic pregnancy with a sensitivity of 100% and specificity of 99%. Treatment consists of medical therapy, methotrexate, MTX, or surgical intervention, salpingectomy or salpingostomy, bilaparotomy or laparoscopy. MTX treatment might fail to treat ectopic twin pregnancies. A surgical approach may be the most appropriate option in these cases, as in the case here presented.